Each evening, at precisely 6:30 p.m., Joe Smith sits down to his supper of pork liver and carrots. It's all he's ever eaten, and he wouldn't dream of ever eating anything else. It just so happens that these two foods have a common component: vitamin A. Joe knows this. He also knows that vitamin A is an essential nutrient that cannot be synthesized in vivo and thus must be obtained through diet. Joe knows that vitamin A has important roles in vision, cell growth and proliferation, immunity, and reproduction. What Joe doesn't know is that too much vitamin A can be just as deadly as too little. What Joe doesn't know is that vitamin A is slowly killing him from the inside out.
Vitamin A, also known as retinol, is a naturally occurring organic molecule. Retinol has a beta-ionone ring, which is hydrophobic, and a long isoprenoid tail with a polar alcohol group on the end. No log POW is known for retinol, but overall retinol is very hydrophobic, and thus is fat-soluble and is stored mainly in fat droplets in the liver. Retinol cannot be synthesized by the body, so must be taken in by dietary means. It is commonly taken in as either retinol esters, especially all-trans retinol palmitate in animal tissue, and beta-carotene in vegetables, or as preformed retinol in pharmaceuticals. Retinol has a very long half-life in the body due to its hydrophobic nature and tendency to remain stored in fat droplets in the liver. Thus, chronic toxicity is more relevant than acute toxicity. After oral ingestion, retinol esters are hydrolyzed to retinol in the lumen of the small intestine by pancreatic esterases along with other intestinal hydrolases. Retinol can then cross the enterocyte membrane by facilitated transcellular diffusion. Once present in the enterocyte cytosol, retinol is re-esterified into retinol esters by lecithin retinol acyltransferase, or LRAT, or acyl-CoA retinol acyltransferase, or ARAT. The newly formed retinol esters are then packaged into chylomicrons in the enterocyte and excitosed into the lymphatic system for distribution. The chylomicrons travel from the lymph vessels into portal circulation, where they are degraded into chylomicron remnants by lipoprotein lipase. Upon arrival at the sinusoids of the liver via the hepatic portal vein, the chylomicron remnants bind to apolipoprotein E. The resulting complex binds to heparin sulfate proteoglycans on the cell membranes of the hepatocytes and is endocytosed. Once inside the hepatocytes, retinol esters are once more hydrolyzed to retinol by retinol ester hydrolases. Retinol then binds to retinol binding protein, which is synthesized by the hepatocytes and is transferred to the neighboring hepatic stellate cells residing in the perisinusoidal space of Dissy. The exact mechanism of the intercellular transfer is unknown. Once inside stellate cells, retinol dissociates from retinol binding protein and binds to cellular retinol binding protein 1, or CRBP1, and is then esterified by LRAT. Retinol esters, mainly in the form of retinol palmitate, are then stored in specialized fat droplets in stellate cells. Stellate cells are the major site of storage for retinol esters in the liver. Approximately 80% of liver retinol is stored in these cells. Throughout the body, 90% of retinol storage occurs in the liver, the other 10% being stored in the kidneys and the adrenal glands. Retinol is transported in the blood bound to RBP, 19 to 21 kilodalton protein, in association with transthyretin, or TTR, which is a much larger 40 to 60 kilodalton protein. TTR increases RBP's affinity for retinol, and due to the size of the RBP-TTR complex, prevents loss of retinol through glomerular filtration. Metabolism of retinol can take place in either the parenchymal hepatocytes or stellate cells. As mentioned before, retinol is reversibly converted into retinol esters for storage. Retinol can also be oxidized via phase 1 reaction to 4-oxoretinol by the cytochrome P26 family of enzymes. Retinol dehydrogenase catalyzes the oxidation of retinol to retinal, which can then be further oxidized by retinaldehyde dehydrogenase to retinoic acid, the latter being an irreversible reaction. Retinoic acid can then undergo the phase 2 conjugation reaction of glucuronidation to the more polar metabolite retinoyl beta-glucuronide. Likewise, retinol can be directly transformed into retinol beta-glucuronide by glucuronidation. Retinoic acid and the two glucuronides, along with many other metabolites not pictured here, are polar enough to be excreted. In general, retinol metabolites with an intact carbon chain tend to be excreted via the bile ducts in feces, whereas acidic, chain-shortened metabolites tend to be excreted in urine via glomerular filtration. Retinol toxicity, also known as hypervitaminosis A, causes a variety of detrimental effects, including increased cerebrospinal fluid pressure, generalized weakness, dermatological manifestations such as drying of the skin and mucous membranes, hair loss, nail infections, bone and joint pain, liver and spleen enlargement, and liver fibrosis, ultimately leading to cirrhosis. As mentioned before, retinol normally circulates bound to the RBP-TTR complex. Free retinol is a highly surface-active, membrane-seeking molecule and can disrupt the integrity of plasma membranes to the extent of creating holes in the membranes. When retinol is bound to RBP, however, it cannot manifest its surface-active membranolytic effects. During hypervitaminosis A, hepatocytes are unable to synthesize sufficient RBP to bind with the elevated quantities of retinol. Retinol then starts circulating freely, or bound to nonspecific plasma lipid proteins, which do not have the same regulating effect on retinol as RBP does. Retinol is then able to inflict damage on plasma membranes throughout the body in a nonspecific fashion. Retinol toxicity is felt most keenly in the liver, causing liver fibrosis and ultimately cirrhosis, which is an irreversible, heavy scarring of liver tissue that greatly impairs liver function, potentially resulting in complete liver failure. Stellate cells are the Dr. Jekyll and Mr. Hyde of the liver, in that they are capable of expressing a dual phenotype. Inactivated, good stellate cells contain lots of retinoid-rich lipid droplets, have low cell proliferation, and low levels of collagen synthesis. Bad, activated stellate cells exhibit myofibroblast-like cell tendencies, loss of lipid droplets, and increased collagen production. In the initial stages of retinol toxicity, stellate cells are loaded with retinol esters and the lipid droplets grow in size. These droplets cause the stellate cells to expand, pushing them into the sinusoidal lumen, and obstructing hepatic blood flow, causing portal hypertension. At later stages of retinol toxicity, stellate cells undergo transformation into myofibroblast-like collagen-producing cells, and lipid droplets inside the cells decrease substantially. It is not known exactly what causes this transition. Although the initiation of hepatic fibrosis in hypervitaminosis A is not known, what is known is that retinoic acid contributes to the progression of and exacerbates fibrosis. Retinoids have known function in cell signaling and proliferation. In particular, stellate cells express genes for nuclear retinoic acid receptors alpha, beta, and gamma, RARs, and the retinoid X family of receptors, RXRs. In advanced hypervitaminosis A, as the lipid droplets in the stellate cells decrease, retinol esters are metabolized, some of them to retinoic acid. All trans-retinoic acid binds to an RAR. The RA receptor complex then travels from the nuclear membrane into the nucleus, where it acts as a transcription factor for plasminogen activator, PA. PA is subsequently transcribed, translated, and assembled. PA then activates plasminogen, turning it into the active protease plasmin. Transforming growth factor beta is the most potent fibrogenic cytokine in the liver, stimulating expression of the fibroblast phenotype of stellate cells and stimulating collagen production. TGF-beta homodimer normally exists in a latent, non-active form, attached to two other related proteins at the interior surface of the stellate cell membrane, latency-associated peptide and TGF-beta binding protein. Plasmin cleaves the latent homodimer TGF-beta protein from the latency-associated peptide, rendering it active in the cell. TGF-beta then stimulates transformation of the stellate cell into a myofibroblast-like cell, causing fibrosis and eventual cirrhosis. While the mechanism linking high retinol levels to initiation of liver fibrosis via activation of stellate cells is yet unknown, here I present a mechanistic hypothesis based on the surface-active membranolytic properties of free retinol. As explained earlier, during high retinol intake, retinol circulates in the absence of retinol binding protein bound to nonspecific lipoproteins. It is then able to disrupt the integrity of cellular membranes and organelle membranes nonspecifically. This happens all over the body. There's no reason why it couldn't happen in the liver as well. If it happens in the hepatocytes, lysosome membranes could be degraded, and reactive oxygen species such as superoxide anion could be released in the cells. These reactive oxygen species could then activate stellate cells. Kupffer cells could also be activated in much the same way by membrane degradation. Apoptotic fragments from destroyed hepatocytes are also capable of activating Kupffer cells, which can then signal stellate cells with fibrogenic cytokines, including transforming growth factor beta, which will activate stellate cells and trigger fibrosis.